before we jump into the talk, I just wanted to give a 30,000 feet view of what we'll be covering today. Want you guys to get a good understanding of what the disease process typically looks like in terms of causation. Why does TGCT occur? What kind of symptoms does it produce for patients? How do we really evaluate it? How do we end up treating these particular options? Kind of track that patient journey, and the different treatment approaches that we see may not get presented all the way to you. The different nodes in that complicated diagram of designing therapies, and then go over what current agents are available, and then finally summarize the new clinical trials that are currently ongoing, and maybe touch on what are the future directions that we need to take in this particular disease process. So TGCT used to be called PVNS, so pigmented villonodular synovitis, which is a mouthful, and giant cell tumor of the tendon sheath is also another synonym for this condition. Now, globally, we have agreed to have a more uniform nomenclature and call it Tenosynovial Giant Cell Tumor. The cool thing about this disease, among the other sarcomas that I deal with, is it's non-life-threatening. It's rare. It occurs in the joint, especially synovial joints and tendon sheaths and bursa, but not necessarily life-threatening in almost all patients. And that's always a relief. So that very fact that this does not actually result in a mortality in patients is a very important factor to note in how we evaluate the drugs that come in this particular space as treatment options for patients, because the focus is entirely on function. So making you feel better, making you function better is really the sort of eye in the needle that every single therapy has to pass through in order to be useful in clinic and to be recommended in clinic. So while we do measure the tumor's function, is probably the most important thing. So it's commonly seen, and this you guys know better than me, it's commonly seen in adults between the ages of 20 and 40, affects the large joints, typically the knee, hip, ankle, and the more smaller joints get affected, the disease becomes even more complicated to deal with from a surgical standpoint and in terms of recurrences. Median time, this is the average time from onset of symptoms to establishing a diagnosis, is still around a year and a half. In patients with a particular subtype of TGCT, and I'll discuss this in a little bit, called the diffuse type, which is more extensive as opposed to the localized type, which is presents in a more confined manner. Recurrence rates are very high in the diffuse type. Almost half the patients will recur. So at the very, very microscopic level, how does TGCT operate? So in most tumors, if you talk about lung cancer or breast cancer, tumor cells make up almost all of the mass, or the tumor that you are seeing in the body of a patient is mostly made up of tumor cells. Now, this is not the case in TGCT. In TGCT, the cancerous cell, which is a cell that repeatedly is making copies of itself, is a minority. The cancer cell or the tumor cell in this particular disease produces an excess of a protein called CSF1, and that basically becomes a attractant for inflammatory cells from all over the body that can then gravitate towards the source of this particular molecule. Here, it's shown uh, as a steel-colored little particle here. It basically attracts inflammatory cells or immune cells from specifically a type of cells called macrophages towards the location of the joint where the tumor cells live. So when you finally see a patient with TGCT in the clinic, most of the tumor is really made up of inflammatory cells. So that's very unique in this particular disease. And also one of the reasons why this disease has its old name called synovitis, because whenever we examined this tumor, it was filled with inflammatory cells coming from different places. We call that polyclonal, or not children of the same mother. One of the characteristic features of tumors is that they are all formed from one single cell that is rapidly proliferating. So they are all children of the same mother, and these tumors didn't have that. They actually had cells coming from different sources. So we always thought this was an inflammatory condition until that was discovered to be untrue. That there is a cancer cell or a TGCT cell. It's kind of awkward still calling this a cancer because it's a tumor. It is a new growth, but it really doesn't travel to other parts of the body and metastasize in most of these cases, and therefore it's really more of a tumor cell in that particular location attracting inflammatory cells into the joint. Now, what's the problem with inflammatory cells getting into the joint? These inflammatory cells are designed to protect our body. They're packed full with ammunition to fight bacteria and viruses, and this kind of ammunition, all concentrated in a joint, starts to produce injury to the joint space itself, and starts to destroy the joint, and then that starts to affect function, and that's the fundamental underlying problem in TGCT. So just wanted to kind of call that out. Very different from other tumor types that start in an area, go to new places, consume the resources there, and end the life of a patient. This does not do any of those things. So we talked about two different types of TGCT. There's localized and diffuse type. So most of the cases are localized, and these patients generally do not recur. Surgically, they are managed. They affect smaller joints. It's limited to a specific portion of the joint, and it's not extensively involving the entire joint, and can cause some degree of pain and swelling. It usually is easily removed with surgery, and they really don't need anything beyond that. So fortunately, most of the cases fit that bill. And then there is a diffuse type, which, as the name suggests, is much more extensive. Tends to affect larger joints as opposed to smaller joints. It can spread through the entire joint, and can be quite painful, limit motion, produce swelling and stiffness, and can be quite chronic and debilitating and difficult to completely remove with surgery. It's important to remember here that even in the diffuse setting, there will be a good number of cases that actually can have, after a surgery, no recurrences. So recurrences are not universal, but there's a very high risk for it, and therefore there is an unmet need for other non-surgical approaches in this particular disease. So how do we typically evaluate them? So there are two parts to evaluate in a patient with TGCT. One is looking at the soft tissues of the joint that is involved. And the second is examining the bone and the bony surfaces. So an X-ray is always, plain radiographs are very important because they tell you about the condition of the joint. And the MRI gives us a very good structural detail in the soft tumor tissue and other soft structures that are present in relationship to the joint. So MRI is the modality of choice when it comes to measuring TGCT. And biopsies are done in order to establish a diagnosis. Most of the treatment for TGCT is administered by oncologists, and they will require some form of a biopsy in order to execute on treatment. So that's about evaluating a patient. I just wanted to call out and say that not all cases would have had a biopsy. A lot of patients, it can be diagnosed with a MRI image, especially in the hands of good radiologists. There's nothing wrong with that sort of an approach. However, before initiating anything systemic, because it also has all these other side effects and potential risks involved, it's always a good idea to confirm diagnosis. So moving on to treatment options. So typically a patient with TGCT, starts off with some joint problems, sees a primary care physician or a sports medicine or a rheumatologist, who then refers the patient to an orthopedic surgeon. And this kind of goes around in a somewhat circular back and forth manner. Many of you have experienced this. And it's usually when this initial surgical attempt to control the disease fails that it gets referred to a cancer-specific orthopedic surgeon or an ortho-oncologist, who will then decide if moving on forwards with more surgery is a feasible or recommended strategy, or should it go to a medical oncologist or a sarcoma oncologist who can then treat the tumor with medical options if surgery itself would be causing more a restriction of movement and more functional debility, or surgery is just not possible because of the extent of the disease. So it's interesting to note here that sometimes in very diffuse situations where surgery is done, you can actually lose some degree of the function in that particular process as well. So it is a complicated decision making, and therefore the position of that ortho-oncologist right there where the initial referral is made is quite important, because only they can make that assessment and then provide recommendations on whether to proceed medically or continue with surgical options. And even if there are surgical options that are going to be pursued, is there any role for investigating or pre-treating with some of these agents in order to improve the outcomes in surgery? Most of that is still very investigational, because we haven't really done trials that have conclusively proven that pre-treatment is actually helpful in outcomes for patients with resectable disease. So that's another topic for a different day. But many of us who do this or take care of patients with this particular condition have noted that they can actually do quite well with pre-treatment, as the tumor generally tends to have a response, and also the likelihood of recurrent disease may be on the lower side. But that really needs to be examined in a controlled, randomized study where half the people are getting surgery without any pre-treatment and the other half is getting treated and then having surgery and looking at outcomes in that particular setting. So we talked about all of this treatment approaches. Really, we use surgery in a good deal of cases. What determines surgery? It really depends on the patient's characteristics, the extent of the disease, and what kind of symptoms and functional debility that the patient has. Surgery typically involves a total or near total synovectomy. Localized disease generally tends to be curative. Recurrence is very low, in the 10% range or even less. Diffuse disease is the one which is a little bit harder to treat, and they can recur in almost half the patients. systemic therapy is mostly reserved only for diffuse disease, and especially when in the unresectable or relapsed setting where patients have had multiple surgeries. Um, so it is ideal for patients where surgical resection can cause significant morbidity and functional impairment. And I know there are groups, particularly in California, that also do radiation therapy for those who are failing systemic therapy, or in settings where it's used in combination with surgery. I think it's a reasonable approach, but needs to be the risks associated with radiation exposure need to be discussed. You really don't want to have a situation where you were trying to get rid of a small pest problem in your house and then burn down the whole house in the process. So we're very cautious with things that have long-term uh, uh, implications, especially in the form of causing additional tumors as a risk factor. So that certainly needs to be evaluated quite carefully. So here's the flow diagram. So we typically think about, surgical procedures first in patients with localized and even in diffuse TGCT if it is operable. There are situations where diffuse TGCT at the initial presentation, because the disease is so extensive, really it requires systemic therapy right off the bat. And in such cases, or even in scenarios like patients going into surgery, consideration of clinical trials is always an important step, because this little circle here is what provides more branches to the very well-growing tree on the left side of the panel here, because these trials provide information that allows us to populate more efficiently the rest of the tree on the left side of the slide here, with better and better side effect profile and better functional outcomes, if you will. So systemic therapy, you can see here, it's mostly inhibitors of that little substance I was describing earlier that the tumor cells produce. We use inhibitors or drugs that inhibit that particular molecule, or the receptor that the molecule binds with is inhibited by it. By treating that, by administering this inhibitor, it causes these inflammatory cells to kind of, wither away and disappear from that local area. But it is a process that takes some time, and I'll show you that in some of the results of the clinical trials that have been done in this particular space as well. So how do you inhibit the receptor for this particular molecule, CSF1? You can either use an antibody or you can use a small molecule inhibitor, and I'll show you examples of both as we discuss the treatment options. So this is a really interesting paper that was published in Lancet Oncology about 3 or 4 years back, that really takes and puts into focus the in a very large population. As you can see here, it's over 1,000 patients, giving us an idea of how many of these particular patients are men and women. As you can see here, about 58% are women. So there is a female preponderance in this particular disease. Most of the disease occurs in the knee, as you can see here in the red box here. When you're looking at large studies like this, one of the key things that kind of come into focus is that pain and function, to improve that is really been the goal all along, whether it's surgery or medical therapy or anything that you are considering to start in this particular patient population. So the broad answer to why do we need new treatment options for TGCT? Why do we want to treat it? It's really to improve upon function. It's to improve upon the success of even our surgical procedures currently, and that's the road ahead of us. So having multiple agents really creates a setting where, depending on the kind of side effect that imagine you're having a drug and you develop a side effect, but most patients do not develop that side effect. You have no other options if you only have one drug to work with. So multiple drugs available in this particular space is really useful when a patient is having a side effect that is cutting in on their quality of life and is somewhat unacceptable to them. So I love the fact that there is a lot of options arriving in the treatment space. The patients always win when there are options available and they can choose and pick what is the right fit for them from the portfolio of agents that are available. So this is basically summary of the surgical options. This is also from the same paper that we were talking about earlier. I think these slides are going to be available to you. The key factor to look at here is that these patients were followed up for almost a good deal of like 5 years or so, nearly close to 5 years, and 44% of the patients developed recurrent disease. And that's the unfortunate situation with a lot of these particular patients, is the recurrences is what really gets to them, and which creates this unmet need for how can we be better at preventing these recurrences in the future. So again, talks about some of the side effects of surgical management, complications, if you will, and it's not a lot. So, which is why surgery always still remains at the top of the list there. 12% of patients reported complications, especially after open synovectomies and after arthroscopic synovectomies. And you can see the percentages here. It's rather low, which is why we still use surgery as our first go-to approach in the management of this disease. But in the era of multimodality therapy, surgical resection alone can no longer be regarded as the only treatment in patients with diffuse TGCT, especially when the disease is borderline resectable or unresectable. And it is an area where we need to encourage even our medical community to consider the medical options and use them alongside in order to get better outcomes for our patients. Because when there is a high rate of recurrence, it is, I think the onus is on us to actually come up with solutions in order to fix that particular problem as well. So moving into systemic therapies, again, we have talked about this, that it's either small molecule inhibitors, they're also called tyrosine kinase inhibitors, and monoclonal antibodies. These are the monoclonal antibodies are administered intravenously, the others are taken orally, and this particular sort of an approach actually is an effective way of really treating patients with TGCT who have unresectable disease. And current FDA approved indication is mostly in unresectable disease. So everything we are going to discuss here is for patients where surgery is not going to be useful, and the orthopedic oncologist has made that clear for the patient. So the first drug to discuss was probably one of the first drugs used in this particular space, which was imatinib. It is a good drug. Its effectiveness is pale in comparison to some of the approved agents we currently have. you'll see here in the green boxes that about 4% of patients had the disease disappear, and about 27% had a partial response. So that adds up to around 31% of patients showing a substantial decrease in size of the tumor. But this readout of the response rate is something we oncologists love to look at when we are looking at tumors. But I again want to call out that the most important thing here is really symptomatic response. So you can see here that 78% of the patients actually had some degree of symptom improvement, which still makes this drug, which has limited toxicity. It's not very strong in this particular application. However, it still has a role, especially if a patient is having side effects to the stronger agents that are working really well, and wants to avoid toxicity, is still a good option to consider. So this is the only approved drug, pexidartinib, at the moment. We hope that that'll change very quickly with the availability of the vimseltinib data that we will be talking about in just a minute. Pexidartinib is a oral tyrosine kinase inhibitor, again, highly selective for inhibiting CSF1R, and it is approved by FDA for treatment of patients with severe morbidity and functional limitations and are not candidates for surgery. The thing about this particular drug that has been very difficult to use in the clinic has been this black box warning of potentially fatal liver damage. So I want to spend a little bit of time on this particular risk that always gets patients really concerned. If you look at this drug and its development, it started off as an anti-cancer drug used in combination with other agents in its early development, used at very high doses. So most of the drugs in oncology used to control cancer are dosed. The dosage testing is basically increasing the dose to a point where the patient hits toxicity and then dropping down a little bit and then trying to use that in a larger set of patients. This has been necessary in the development of chemotherapy, but it's really debatable in biologically active therapies like pexidartinib and TGCT. Do we really need to have such high doses to be used, and can smaller doses work with less toxicity? Unfortunately, in the initial development of the drug, the toxicities that appeared, especially at the higher doses, have resulted in this black box warning. So the liver-related toxicity potential is a real one that we do have to monitor for. There is a program, a risk mitigation program called the REMS program. Those who are on pexidartinib are quite familiar with it, where we check your liver function, especially during the first couple of months, very carefully to make sure that you're not developing any liver toxicity. This is absolutely necessary and to ensure your safety, and allows us to actually use the drug in the clinical setting with the monitoring. For patients who are reluctant to start therapy on it, I always call out to the doses that are listed here. This is a flow diagram from the study, where you can see here in the drug arm, the pexidartinib arm, the dose was the dose that was being administered was 1,000 milligrams per day, split, and which is a far cry from where the dose is today, where the modified new dosage, where with a low-fat snack, the drug is actually provided in 125 milligram tablets that are taken in 2 at a time So that dose, only 25% of that particular dose is currently being utilized. The reason for the low-fat meal or the low-fat snack along with it is because this drug is very sensitive to the acidity in the stomach in terms of its absorption. So when eat anything fatty, you secrete more acid. You know this from your movie and pizza nights, that how you feel after you've had a few slices. The secretion of acid in the stomach makes the drug way more soluble, and which means it gets absorbed quite rapidly when more acid is present in the abdomen. So this is why a fixed amount of fat allows us to limit excessive absorption of the drug. If you were to take 1,000 milligram dosing with a Texas style breakfast, you're going to have drug levels that are extraordinarily high, and you really don't want that to occur. So the drug and its solubility, which is really dependent on how much acid you are secreting, which is in turn related to how fatty sort of a meal that you're eating, is what causes us to administer it with a low-fat meal. So it's very important, and I tell all of my patients that it's important to kind of adhere with that specific requirement so that the absorption is not excessive. So the design here, you can see here, the patients were given pexidartinib. 60 patients received that, another 60 received a placebo. And this was continued for 6 months to effectively determine that, that patients are deriving benefit. And then the label is opened and everybody gets the drug after the part 1 phase. So these are some of the results and on the basis of which the drug really got approved. The pictures say it all. You can see in a matter of 2 years, a hand where you cannot even see the fingers because of how much the disease has overgrown is beginning to actually have a functional hand that is evolving, that has some more semblance to normalcy here. Again, you'll notice here that the response rate originally described here, the overall responses that you're seeing here, 39% up here. As time moves on, the response rate is increasing to 53%. Again, this indicates that over time you are recruiting. So this tumor reduces in size slowly over time. So unlike many tumors where you see maximal response in 2-3 months or whatnot, this is not the case here. The longer you stay on the drug, the more reduction it really produces, which then again makes the whole decision of how long to treat somewhat complicated, and it really depends on the individual patient. I always try not to go by just the reduction in size. While it's very reassuring for me and also for the patient, focusing on function is so important in this particular disease. Here are the long-term study results. So let me just explain these graphs a little bit. So you can see here on the y-axis, it really goes from 0 to minus 100%. Minus 100% decrease means the tumor has disappeared. 0 means it has not changed at all. So the patients are all lined up here in the increasing amount of response that they have had. So the ones on the right-hand side, which have reached minus 100, are the ones where the tumor has completely disappeared. And the ones on the left, where there is a minimal decrease, are the ones where the tumor really hasn't changed by much. And you'll notice here that this portion where they have had 100% reduction, as time moves on, as each of these graphs are representing analysis that is done further and further out, And you'll notice that this part, which is very thin here, is getting fatter and fatter as time moves on, as more and more patients are recruited into the response category, bringing up the overall response rate to around 60%. So this is, I guess the take-home message here is that duration on drug, the longer it takes, it does have an impact on increasing the response. But it's important to really prioritize function, which you will know whether you are benefiting or not when you're on the drug. Another drug I want to briefly mention and not spend too much time on is nilotinib. It actually has a good activity against CSF1 receptor. It's really not a go-to drug in many of the situations because we do have drugs that are more effective and less toxic. So we do, but it is an option in patients who want to try something because of side effects to other drugs. Mactuzumab is the antibody version of this drug. So instead of the oral therapy, this is more an antibody-driven administration, and it also produces, as you can see here, response rates are 70%. So 70% of patients get a substantial reduction in their tumor size. But again, most important thing to focus on is, again, function here as well. So it's a good drug, and it is a macromolecule that can be administered IV and safe to use in this particular condition. Not approved, but these are studies that are available in order to suggest additional agents if the need arises to engage these particular agents. So bringing up to the most recently exciting results that have come through about a couple of weeks ago on October 30th, actually. The phase 3 study results were out where we compared the use of vimseltinib against the placebo or sugar pill, and the results are quite favorable. We believe that the drug will get approved by our regulatory bodies and will bring on yet another addition into treatment of TGCT. The unique feature of this particular drug is, again, it binds way more selectively to the CSF1 receptor, again, an attempt to reduce toxicity. You can give it orally, and the drug works quite effectively, as I'll be showing you in the follow-up panels here. You can see here response rates are all running into like 70% of patients deriving benefit, quite impressive. And of course, there's also a good deal of functional improvement in this particular patient population. Toxicity, none of the fatal liver toxicities were really apparent with vimseltinib. So we believe that it hasn't shown anything so far, which is a very encouraging piece of information. But you'll notice here that, the number of patients in these different cohorts that were treated when we are looking at the phase 1 study or on the subsequent studies is still a small number of patients. As the experience builds with this drug, we will become more and more aware of what kind of toxicities we are dealing with. The safety profile that we are seeing currently has been amazing. So really excited about having this drug available in the clinic. Some of the side effects that have been observed have been joint pain. Again, this is kind of hard to interpret because a lot of patients have also joint destruction that is occurring as a result of the disease itself. But there have been situations where pain can actually be reported, sometimes worsening in the short term on drug as well. There is complaints of fatigue, which has been a problem with both pexidartinib, and I suspect most of these drugs will have fatigue as a side effect, and one that will have to be combated by a reduction of doses when possible. Periorbital edema or edema swelling around the eyes is a problem, especially among young folks. It's a significant issue that we're hoping that it will not be prohibitive enough for tolerating therapy in most patients. So again, is a deeper look at the phase 2 data and some of the safety readout that came out of it. You'll see here that there is elevation in CPK enzyme that is seen in about 38% of patients, especially profound elevations. Again, I wouldn't really call this a safety problem because this is occurring primarily because this enzyme is typically cleared by macrophages in the liver. And when you give a drug that kind of inhibits their function, you are going to have more of the CPK hang around. And that's just tells you that you're actually getting the effect that you desired. It really doesn't pose the kind of risk. I think lots of oncologists are a bit worried about CPK. The elevation of CPK, which is a muscle, which can occur when muscle is breaking down, a serious problem, is not what is operating here. This is just an isolated elevation in the enzyme. It's a lab abnormality. You would not feel any different from a symptomatic standpoint, nor does it pose a threat to your medical condition in any shape or form. So there are also other liver enzymes that can also be whose clearance can also be affected by the drug. Again, it just speaks to how effectively it inhibits the Kupffer cells or the macrophages in the liver that are usually responsible for clearing these enzymes out. And when they don't do their work, the enzyme levels obviously go up. So again, here, this is the phase 2 study results, and you can see that overwhelming number of patients are still remaining on therapy, really promising anti-tumor response, and almost no patient really is progressing or where the drug doesn't really work, which is quite exciting. It's almost like 100% clinical benefit. Clinical benefit is any patient who is getting either their shrinkage or their tumor is no longer growing is considered clinical benefit. So very impressive out there, and also improvements in function. So this is the exciting piece, the phase 3 data on the basis of which the drug is likely to get approved, highly likely. So it was the results suggest that it's very safe and it's well tolerated. Did not really show any evidence of hepatotoxicity or liver damage in the population of 80 plus patients who've been treated with the agent. So the preliminary studies show the preliminary results show a statistically significant and clinically meaningful improvement in the disease process, both by measurements of it, by tumor volume scores, and also from the most important thing here, item number 5, the range of motion is substantially improved with vimseltinib, which is really the reason why we put these patients on study. So want to kind of wrap up with some of the newer agents, more exciting things that are also coming into evolution as, and one of them is the compound made by Ammax Bio. This is a localized monoclonal antibody that binds to CSF1. So the innovation here is rather than give it IV, where the drug goes all over the body and produces side effects in multiple regions, can we really limit the toxicity by just administering it in the joint? So this is a really good from at least from a strategic standpoint, it's a really good strategy. We hope that this is successful. But the reality of it is that the joint also has quite a bit of blood vessel rich tissue there, which will cause some degree of absorption into the rest of the body. But we are hoping that it'll still give us an advantage over systemic, or give rather than giving it all to through a vein for all parts of the body, just localizing it only in the joint will give us some strategic advantages in terms of toxicity. So this again, so the study is currently accruing. We have it open here, and as do many of our sarcoma centers around the country. So if you please reach out to the LifeRap group, and they can provide guidance on what would be the closest center to you if you want to get access to the drug. Another drug that is currently being investigated is pimicotinib, also a highly selective, potent CSF1 receptor inhibitor. And they also are in the process of doing a phase 3 clinical trial to evaluate both safety and efficacy. Their evaluation of overall response with a treatment duration of 6.8 months suggests a 68% response rate, very close to the efficacy that you have seen in the previous slides. I think the important thing to kind of remember here is that all of these drugs, pexidartinib, vimseltinib, and pimicotinib, are all effective agents. They do have differences in their effectiveness and in their toxicity profile, or in other words, the side effects are different. The availability of all agents gives us the opportunity to pick and choose for a given individual patient what is the most ideal drug. So I do think that the development and eventual availability of this particular agent will be highly useful in the treatment of TGCT patients. So this is the study design for the pimicotinib trial, which is very similar to the study design that was used for both vimseltinib and pexidartinib. There's two groups of patients. There's a group that gets the drug and a group that gets the sugar pill. There is a period of 6 months where patients are getting the placebo in this particular study, which often raises the whole question about whether or not it's a good idea to participate in a study. My opinion is that the availability in the treatment of TGCT, it is very, very critical to have a good portfolio of agents to pick from. I am aware that there is no mortality associated with this disease. I'm quite comfortable with a run-in period where a patient may not be on drug. It allows us to really quantitate the benefit that is associated with the drug in an experimental design. So at a time when the drug becomes available, we'll be able to actually accurately say what is the true contribution of it. And all patients will go into the open label or part 2 of the study, where they will get the drug anyway. So if patients are not having substantial symptoms and are consenting to participate in the study, I think it does open up an exciting opportunity of yet another agent which may not have the same side effect profile of the other agents which are currently available, another option, an effective option to choose from. So lastly, for future directions, incorporating these drugs in even resectable patients, or what we call neoadjuvant treatment before surgery, is poorly understood. And I think a good study in this particular space would be extremely useful for patients, because we are really in the business of trying to see if we can actually limit exposure to the drug as much as possible. Perhaps the best place to do that is in a patient who is recurring for the first time, utilizing the drug early so that they never have to be on the drug and they don't get a recurrence afterwards. So that would be ideal. So that's another area that we certainly want to develop. And also, even in the existing drugs that are available, how low can we go in terms of the doses? How can we minimize side effects even better than what we are doing? What's the optimal duration for which patients need to be treated? How long can we discontinue? Can we stop it in November and then re-pick up at a time where the patient is starting to develop symptoms or progression? And that's those are the questions that need to be answered. There was a very interesting study that was presented last week by Dr. Stacchiati in Ireland, where we all met and we were discussing how to treat this condition. And it's interesting that, when the therapy stopped, only about half the patients will have worsening of the disease. And, some others, they can actually keep on going for a year and a half without drug. So a discontinuation way of administering therapy is very much a reasonable way to treat this condition. So I'll stop there and kind of take the questions and spend time on that. Sydney, you're on mute.
Thank you. Sorry about that.
Yes.
Thank you very much for your presentation. We have quite a few questions. Would you be willing to stay 5 to 10 minutes extra so we can get through some of them?
Happy to stay as long as it takes.
Oh, perfect. Oh, I disappeared for some reason. Okay. Oh, now you disappeared. I don't know what's happening. I'm so sorry.
Maybe see. I should stop sharing.
Okay. Yeah, that works. So starting with, are there special MRIs which are used to detect TGCT versus maybe regular MRIs?
I think at least when we are utilizing MRI in clinical practice and broad-based clinical practice, the MRIs we normally get are going to be just fine. In the research side, we do have varying more sophisticated tools to measure this. I think the important focus is really to make sure that there is some examination of the joint. A lot of us who are experts in this particular field don't feel that, oncologists have a habit of ordering MRIs every couple of months. I'm guilty of the same problem because we are so used to looking at the tumor. And TGCT is a good reminder that we need to focus on how well the patient is doing. So most of the information really will come after the question, how are you doing today? And how has things been since we last met? Gives you more information than the MRI ever will. So I just want to call that out. But yes, there are functional constructs that have been built into MRI. This is to look at the consumption of glucose within the tumor, a combination of PET along with the structural imaging like CT or MRI, and also traditional MRI, contrast enhanced MRI. All of the above are useful in their own ways in trying to understand the tumor better.
Thank you. Another great question someone asked. So when you look for the genetic testing for CSF, that abnormality, right? It's only in the joint. It's not necessarily in the whole body. Is there any benefit to testing how much a single patient has versus another patient, or does that influence response to drugs?
So that's a good question. I don't think that this genetic abnormality is a germline abnormality. It's more localized to that particular joint. There are some exceptions in patients who are getting multifocal TGCT, so we won't complicate our discussion today with all of that. But I don't think there's any particular practical value of trying to do that. I think the sensitivity to keep in mind that the target, the CSF1 receptor, is not is actually on the macrophage. It's on the normal cells that are in your immune system. And getting them to leave the site of the crime is really what we are trying to do. And they like to peel off at a variable rate slowly over time. And that's kind of consistent across all of the agents that we are looking at. So I don't think it's the absence of the target that why some patients are getting less of a robust response. It just takes time, and in some patients, the volumetric reduction is different from other cases. But yes, the presence of the CSF1 receptor bearing cells and the density of them is going to be a very important factor in how effectively they disperse off. Again, and this is also where the different drugs are going to have advantages, like vimseltinib, with its high affinity for this particular target. They are able to overcome some of that. The whole switch pocket design of the drug itself has substantial advantages in its very specificity and in trying to induce responses. So something to kind of keep in mind.
You mentioned Sylvia Stacciati and a few others throughout your presentation. They were all part of a recent consensus paper. And so someone had asked, how has that consensus paper changed your treatment at all, or has it changed your ideas?
I don't think the consensus paper really kind of stood on the areas where we had some firm knowledge to kind of stand on. What the additional data that is coming in with long-term follow-up, this is Dr. Gelderblom's presentation and Dr. Stacchiati's presentation. All of them, what they are suggesting is that the responses can evolve over time. So if you don't see a response at 6 months, it doesn't mean you're a non-responder. You're just going to be a late bloomer there, and there's nothing wrong with that. You just wait and wait for that response to evolve. And again, Dr. Stacchiati's presentation really calls out to the fact that if a patient stops drug, you don't have to, like, as a knee-jerk reflex, start it back on because there is some movement on MRI. You can wait until there is some degree of symptomatic component and then restart. Some patients don't tolerate drug discontinuation at all. When you stop it, they get quite a bit of pain, and you have to individualize your strategy depending on who you're dealing with. And again, keep it also in mind that sometimes pain can be from the joint destruction itself. So it really takes multidisciplinary care. Working closely with the orthopedic oncologist and the orthopedic surgeon is going to be a critical need as well.
So we kind of throughout the presentation had a very US focused view. Do you have any advice for patients in other countries where they may not have Turalio, for an example, or any approved option?
Yeah, I think it'll change in a few weeks. So I'm extremely glad, and the whole purpose behind even Sylvia's data being presented was to just convince the regulatory bodies that the liver toxicities, we don't see anything past the first 8 weeks, and these patients are doing fine, and the drug is safe to use, all of which is really useful things, even for the continued use of pexidartinib. And I think it will be continued to be used depending upon what kind of toxicities patients are having. We may have to switch around. Keep in mind that this is a disease that does not do anything to the survival or the lifespan of a patient. So I don't think they're just going to be addicted on one brand unless that drug is so effective and produces zero side effects for the patient. So when there is a problem, having other tools that we can switch around is certainly very, very helpful.
So speaking of some things we don't know, do you have any recommendations for those that are concerned about fertility when it comes to the systemic therapies, or would they choose maybe a imatinib or something that's more well known, or how do you counsel your patients on that specific part?
Yeah, and I think the key thing to kind of remember is that I would use the whole discontinuation data, which is when drug was stopped, a good proportion of patients, nothing happened. They were able to, and the duration for which they stayed without therapy is quite long, longer than it takes to actually bring a pregnancy uh, to completion. So I do think that, if at all there is a plan for fertility, to discontinue and then picking up after later is a very reasonable strategy to take, and it's very safe to do so unless there was such overbearing pain. But in a multidisciplinary fashion, with the help of the orthopedic surgeon as well, I think we can actually help patients go through that particular phase if they have not already completed their family.
Thank you very much. Wonderful consideration, and I know many of the young patients are always wondering that one.
Yeah, I certainly don't recommend being on the drug and then, the long-term effects on that sort of a situation clearly has not been studied and is definitely not recommended. So please talk to your oncologist, and they would be more than happy to park a very well-planned pregnancy around the treatment.
So we can see through many of the conferences that there's a lot of education within oncology communities. Is there any attempt also to disseminate that information amongst other communities like orthopedic surgeons?
Yeah, there's quite a bit of effort going on to make sure that, there's good education spanning across all multidisciplinary specialties to understand that this is an interesting option that is available for treatment of patients. And also, I think this education will automatically come in once we start the clinical trials where pre-treatment before surgery, and as orthopedic oncologists and I don't think the problem is with orthopedic oncologists. I think orthopedic surgeons who don't deal with this on a regular basis and haven't used any systemic agents are the ones who are going to be quite pleasantly surprised to see pre-treatment actually makes their life a whole lot easier, and that will actually bring up a greater utilization, I believe. But we've got some ground to cover before we get there.
And referring to you guys at multidisciplinary centers with the experience to actually treat the disease.
Yes, that's quite useful in the diffuse setting. But I'd really like to get these particular patients a bit earlier as well, because it actually helps us to keep them off drug if we can actually catch them before the tumor is extensively grown.
So speaking a little bit more about drugs and side effects, are there any side effects that stand out in particular drug, excluding the white hair and hepatotoxicity? Is there any drug, for example, that causes edema at like a higher rate?
Causing what? I'm sorry.
Edema?
Yeah. Swelling has been a problem. The periorbital swelling has been an issue. And it's a class effect also, because everything from imatinib and every other drug has actually produced it. So it's kind of hard to hit a target and not have some of the normal physiological consequences that are present in the body not evolve. So I think some of the side effects of edema is always going to be there. With specific agents, we can certainly switch around and see if it is less with another agent that is available, so that the patient can be taken care of a little bit better. The newer agents, like for example, pimicotinib, my boss who trained me always says the enemy of good results is long-term follow-up. So what he's saying is, as we put more and more patients on a drug, and the longer we know a particular drug, it always starts to look a little less in luster, but because you know more about it and you have a much more comprehensive understanding of it. So a lot of the drugs may look a lot attractive, but over time we will be able to understand the true benefit of it. I do believe that these newer agents that are coming in are certainly more exciting and less toxic, and are being dosed at a dose that are specifically picked to minimize toxicity, which is very different from how we originally started to make this journey with pixidartinib, where we were using very high doses. So that transition of not to use the highest dose, but how low can we go, is really going to be the journey going forward. So even the side effect profile of many of the available agents, as they are titrated down in dose, and the data of how we can use intermittent therapy will affect how these drugs are utilized in its final state.
So just a last effort as well to cover all of the questions that I can, is at MD Anderson, what trials are currently available, right? You said pimicotinib in the AMD is kind of figuring itself out.
Yeah, so our intra-articular AMMAX trial is certainly open, where it's really for patients who are not with the advanced disease. It's for the earlier state where the joint the tumor is still confined within the joint kind of patient population. So that's for that segment of the patient population. And for patients with advanced disease, pimicotinib is still available as an option. Vimseltinib, as you know, the trial has closed and the results are currently being curated to present before the regulatory bodies. So once that gets approved, we will have those agents available as well.
Well, thank you so much for your time. I will also, for anybody watching and wanting to watch again, post this shortly on our YouTube channel. And any questions you can send to me. And if Dr. Ravi is willing, I will send them off and make sure people get their answers as well. So thank you very much. Thank you for spending your evening.
Thank you for having me.